trials.
Thank you again. It's my pleasure to be back, and we'll discuss the TAVR for all. So I think the question mark we'll try to remove, but that is the goal of the talk. As you know, there are so many commercially available TAVRs currently. So there are balloon expandable valves, and I put it there. Self-expanding valves, there are other design or mechanically expandable reorienting valves, and all these different types of valves are available, and we have now new data for the low-risk trials. Just to give a perspective that we started the first TAVR in 2005 in the United States, and now if you look at it, there are 587 sites. 587 sites in 51 states. So this is a procedure that is widely available, very widely available in United States. And within last 2 years, as you can see, there are almost 40 sites that open. And if you look at this is United States, so in 2017, there are 51,000 transcatheter valves done. The red is valve-in-valve, 3,000 valve-in-valves. So totally 55,000 valves. And last year, in the first 3 quarters, we have 51,000 valves. So the last quarter were another close to 12,000 valves that were done in the United States. So this number is astounding. This is a very large number of patients. And why is it possible? As you know, the reason why it's possible is because we have randomized data from each of the subgroup of patients, from extreme risk, high risk, intermediate risk, and now low risk trials. And as I pointed out, that these are the main randomized trials for both valves, the balloon expandable and self-expanding valves. So if you look at this is a little busy slide, but we'll spend 1 minute on it to say that if you take inoperable patients, high risk patients, intermediate and low risk patients, this is before the last 2 trials that were published. And if you look at 30-day mortality, 30-day stroke, and 1-year mortality, in each of these trials, you can see very clearly that if you compare the notes, they look incredibly similar. At least the TAVR does not look worse than surgery with any of these numbers. If you look at any of the 2 pairs, you will find that the numbers are extremely comparable. And now this is a little bit more detailed to see that if you are going to compare, I was going to see if there's a pointer. If you are going to compare, these are the 2 studies, and if you compare all different major complications, they are again, except I didn't put the pacemaker, but the pacemaker will be in favor of surgery. Other than that, everything else is in favor of TAVR or not as good with surgery, except in the P1A 2.4% stroke rate with surgery. This was the trial where we did not have neurologists see the patient. So there was some ascertainment problem with this particular trial. So this is the only trial where there is surgical stroke rate is 2.4. Ultimately, after that, it was always 6% stroke rate in high-risk patients. So just to confirm, just to have that clear, that the stroke after TAVR is definitely less than surgery. And this is the paper that we wrote just recently to say that if you compare TAVR versus SAVR, that even though the stroke risk may be similar in the first day, the risk of major stroke, high-risk stroke, is definitely higher with surgery compared to TAVR. So there is no question that surgery does not provide any benefit for the stroke prevention either. So there are the 3, as you know, that the partner trials, there are all the partner trials, and the partner 3 trial, I'll just go over the partner 3 just briefly. So this is the low-risk trial, again to know that 4% STS or less were enrolled, only TF, so no alternative access, 1-to-1 randomization. And if you look at 30 days, 6 months, and people will be followed for 10 years, right now we have 1-year data. Very important thing to understand is that the inclusion criteria, of course, are the low-risk patients with severe AS, so this is not low-gradient AS, and the ejection fraction less than 50 were not included. And if you look at here, the anatomical exclusion criteria. So there were some anatomical exclusion criteria. So when you say TAVR for all, you are going to exclude the patient who are not good anatomical patients for TAVR. And what are not good anatomical patients for TAVR is severe calcification of LVOT, vascular anatomy, which is not suitable for transfemoral. As I said, we did not include alternative access patients. Complex coronary artery disease, so syntax score more than 32 were not included in this trial, and low coronary takeoff. So remember that we can predict most of the time the coronary occlusion. Very interesting that even after the core lab review and a very careful assessment of the coronary, there was still one patient who had a coronary occlusion in low-risk TAVR group. So these are the important things to keep in mind. SAPIEN 3 was small valve, and as you know, the non-hierarchical design was done. Importantly, the follow-up was outstanding. So the trial is superbly conducted. Sushil, myself, were in the steering committee too. And here you can see this, that the baseline patient characteristics, again, to understand that the patients were about 73, 74 years of age, so they're not 60 years of age, a male predominant lesion, and predominant group of patients. And here you can see that the comorbidities are extremely low. Very, very few comorbidities in these patients. Aortic valve gradient is high, mean gradient is 50, EF is normal, and not much MR, not much, I'm sorry, it went back. Not much MR or TR in these patients. Procedural outcomes, so procedural time is 60 minutes for TAVR. So again, the TAVR is done with expert people very efficiently. You will see that 35% of the people will still general anesthesia. So this is still done 65% local anesthetics, 35% general anesthesia. And concomitant procedures were done, and this is also important. Some people raise an issue with this, that there were 8% of the people with concomitant procedures in TAVR and surgery 26%. Out of 26%, only 12% were CABG. The rest were appendage occlusion. Some people had mitral valve repair, very few, and some people had tricuspid ring, some people had atrial fibrillation related surgery, MACE procedures, and things like that. But the sensitivity analysis of all of this is done and available in the supplement. So after excluding each of these concomitant procedures, still the results were the same. And it is available in the New England Journal supplement. So this is an important question because this commonly comes up as a criticism of this trial. The hospital death, see this, 0.4% and 0.9%. So both surgery and TAVR provided outstanding options for patients with low risk patient, symptomatic patient. And as I said, coronary obstruction was present in 0.2% TAVR. Very interestingly, even with surgery, 2 patients had coronary obstruction. Ventricular perforation with 2 patients, annular rupture, nobody. Primary endpoint. So primary endpoint is death, stroke, and rehospitalization. All strokes, death, and rehospitalization. 15.5 versus 8.5. Half. So we are looking at p-value of superiority 0.001, non-inferiority, of course, 0.001 and less. So this is, and if you look at each one of the endpoints, so if you now look at all-cause mortality, 1% mortality at 1 year. So this is at 1 year. 1 year mortality of 1%. Amazing. And 2.5% for surgery, which is also amazing. But this is almost better than surgery. So 0.09 p-value. And if you look at all strokes, now we are talking about all strokes, 1.2% stroke rate, 3.1% in surgery. So all strokes, 1.2%, and ranking 2, 0. So no major strokes with TAVR at 1 year. And this was without emboli protection, because emboli protection was not used in this particular trial. Death or disabling stroke, 1%, because there are 0 strokes, and 3.9. And if you look at the p-value, is 0.03. So at least at 1 year, you have less strokes and death, disabling strokes and death with TAVR. It's very difficult to beat this kind of data. Rehospitalization, 7% versus 11% in favor of TAVR. And now look at other endpoints. So bleeding, major vascular complication, AKI, and we are not talking little bit less. Even pacemaker, no different. New onset bundle branch block was higher, but coronary obstruction, aortic valve, endocarditis, nothing is in favor of surgery. And that is true for 1 year also. Except for left bundle branch block. New onset left bundle branch block was more and interestingly enough, this is the only trial where surgery did better with hemodynamics, because all different kinds of valves are allowed. Annular dilatation was done, annular enlargement was done with surgery. So the surgery had a little bit less gradient compared to transcatheter valve. However, if you look at the patients with PPM, they were not that different. So this is, although statistically different, of 2 millimeter difference, the clinical difference was not tremendous. Gradient was also less, and aortic valve area was larger by 0.1 with surgery. Paravalvular regurgitation less, and again, to see that 70% of the people had none or trace. So this is also amazing. This number for the CoreValve trials, as you will see, is in the range of 30%. So this is none or trace is 70%. Now, how does it compare to other trials, surgery? So if you look at this, anesthesia time, very similar. You got to operate. Procedure time, very similar. Cross-clamp time, very similar. This is high risk, intermediate risk, and low risk. So you are still doing similar things with surgery, clamping the aorta. Bypass time, very, very comparable. And ICU, 3 days still in the ICU, and 7 days in the hospital. So even though it's a little bit less, it's still out there because there is certain things that you got to recover from. And if you look at the death and all this, much less. So of course, from 8% to 1.3%, so surgery was amazing for low-risk patients. So if you compare it, it is very interesting to see that. TAVR comparison. Look at this. We went from 6.9, we already were 2%, 0.4%. And 0.4%, 0, this is just unbelievable. And procedure time, these are all minor complications, better. Fluoro time, 14 minutes. From 31 minutes to 14 minutes. ICU stay 2 days still, but length of stay 3 days. Still some people keep them in the ICU. We don't, as I talked in the previous talk, we don't have ICU stay, 0. And if you look at all other outcomes, life-threatening bleeding, everything, in single digits. So we were in double digits, life-threatening bleeding, new onset atrial fibrillation 5%, permanent pacemaker 6.6%. So based on this finding, it is preferred to use TAVR in low-risk patients. It's not that it is an option. It is preferred to use in low-risk patients. And it is independent of surgical risk. So if high risk, intermediate risk, low risk, TAVR is better or same. And of course, you have to still use the heart team to say that if a very young patient, a patient who has anatomy is not good, then you may want to use TAVR. Now, how about the CoreValve data? So similar data. So 1-to-1 randomization, TAVR versus SAVR, and 74 years of age. So very, very similar patients are enrolled in 2 different trials. A little bit larger trials, 725 in each group. And again, if you look at the mortality and disabling stroke, so now this is not all stroke, this is disabling stroke only. So if you look at mortality and disabling stroke, it is 4.6 and 2.7. So remember, it was 1 in the other trial and 2.9 in the partner trial. So this is a little bit different, but still it is fairly low and again in favor of TAVR. Mortality, 2.3% here. So it is slightly higher again. So this is all-cause mortality at 1 year instead of 1%, and 3%, 2.9, very, very similar to surgical mortality that we saw in the partner trial. And disabling stroke, 0 versus 0.7, so very similar. And the surgical stroke rate, very, very similar, 2.3%. So the data are very consistent between the 2 trials. And heart failure hospitalization, a little bit less, 7 versus 15 here, 3 versus 6.4. So again, it is a preferred strategy for the patients with severe AS at low risk surgical mortality. This is, I just put Cleveland Clinic data there too. As I showed you before, 494 patient. This is in the high risk and intermediate risk. How are you going to send this patient to surgery? 0%, 0.2% mortality, 0.2% stroke. 0.8% more than 2 plus AR, and 5% pacemaker rate last year. It's very, very difficult to justify surgery. Why can you now justify surgery?
3 minutes.
What is the durability? People say that, well, we don't know the durability of valve. What are the predictors? What is the penalty for this? So the durability, so we just published this thing. We looked at, I put a fellow to look at all surgical literature. I said, look at every paper that exists for surgical follow. 250 papers. She looked at 250 papers, make tables, make graphs. 11 different definitions. 11 definitions exist for surgical durability of valve. The most common definition is need for reoperation, or patients who underwent knee reoperation. Patients who underwent reoperation at the old age is less and young age is more, of course, because they don't go to another operation. They are not operative candidates at this point in time. Follow-up is not complete in these patients. So the conclusion, and we published in JAMA Cardiology with Dr. Bob Bono, and a lot of surgeons reviewed the paper, and I have Dr. Blackstone as one of my authors.
2 minutes.
And Dr. Swenson. Same thing. So we said that this data are uninterpretable. So you cannot really compare it. Durability, if you go for 5 years, at least head-to-head, 7 years, very similar data. And in the NOTION trial, if you look at the VAR criteria, the surgical durability was surgical SVD, so valve deterioration, was 24% versus 4.8. And you look at more than 12% gradient, more than gradient, everything in favor of TAVR valves. Subclinical leaflet thrombosis. Of course, a little bit more with the TAVR valves, but what does it mean? Nobody knows, except that there may be deterioration, which we didn't see so far. And what are the patients? So if you are not taking anticoagulation valve in valve, less than 23 millimeter valve, or the valve is not properly expanded, or the valve is placed a little bit low. So if you put the valve low, then the drainage is different, and you may get in the balloon expandable valve, this is already published, balloon expandable valve, there may be more leaflet thrombosis. And in our data, this is Cleveland Clinic data, so if you put it more than 8 millimeters below, valve depth is 6.5 or below with balloon expandable valve, we did have a few valves that had higher gradients. So over 8 years follow-up. So this is 8 years follow-up. So what is the correct thinking to finish on time? The correct thinking is that surgery for low-risk surgical patients or TAVR for low-risk TAVR patients. I think what we have to do now, of course, these are the areas where we are still working, and you heard a lot of talks about. What I say, TAVR for all, yes, consider TAVR for all. If they are not good TAVR candidates, then consider SAVR. Then you have SAVR. What is not good TAVR candidate is the anatomy is not good for TAVR, meaning that a lot of calcification, roots are not right, annulus is not right, bicuspid valve, we still have to answer the question. But then you consider SAVR, and again, if they're not SAVR, good SAVR candidates, then again you can come back to TAVR, depending on the risk benefits. That's where the heart team is. So currently, for all patients with aortic stenosis, I think it is necessary to consider TAVR. Thank you for it.
Well, Dr. Kapadia, the data is compelling, but I would propose another paradigm, and I'm sure perhaps in future it may become reality. I would take the risk completely out of the denominator. And I would propose, as a clinician who wants the best outcome for my patient, if my patient is less than 65, we'll have an AVR, and if the patient is over 65, we'll have a TAVR. I would introduce the age denominator rather than high, low, medium, and all the nonsense.
I have a better, easier way out. I say that if you are going to consider mechanical valve, then have surgery. We don't have mechanical valve. But if you are going to consider bioprosthetic valve, then forget about 65. If 65 you are going to put bioprosthetic valve, then you better consider TAVR. So, and the TAVR is not good for all 65 if the anatomy is not good. So again, I think the age is a reasonable cutoff, but my sense is that mechanical or bioprosthetic valve should be considered. So if you say, hey, I'm going to open the guy's chest and put a biological valve, then I have a problem if the anatomy is compatible with TAVR valve. That is the only thing that I am just raising.
I would like to make my own comment here, saying that I agree with you, Dr. Kapadia. We have to separate the patients in those who are good candidates for TAVI or TAVR. Anyway, I am sure that you appreciate that here in Europe we have accepted
Sure, TAVI. I should say TAVI, yeah.
Okay, great. It is because Patakos Jr. who brought this experience. Anyway, so we have good candidates for TAVI and bad candidates for TAVI or TAVR. Now, we have to take into consideration two very important issues. One, as we just running 10 to 15 years of the history of this business, we are even today discussing so aggressively. So imagine 10 years later. Yes, everyone is going to get TAVI stent of surgery. And also we have to take into consideration the fact that the biomaterial are improving, the techniques and the biomaterial, okay? So industry is doing its best to find the ways to increase the bulk of the sales. And as such, I am very optimistic that you will be justified. And even at the ages of 25 or 35 or 40, in 5 to 15 years from now. And something else. Nowadays, human beings don't hate scars, and they like miniatures devices and scarless techniques. This is a general message.
I want to caution one thing.
Scar, actually. It's
I know. I want to just caution one thing, that one other thing you want to consider when you put a valve is that what would be the valve-in-valve strategy for the future. So if you are going to put a valve such a way that you are going to compromise the future coronary access when you put a second valve, not the first valve, but even the second valve, or so the STJ is low, you are going to cover it up with the leaflets, what is the size? So it is not a simple decision to say that all patients have good anatomy for TAVR. It requires a real expert to say that in the future, what will it look like when you have to do valve-in-valve. And so there are some patients that I would say that it is better to do surgery, even if the first valve is a good anatomy. So these are all good questions to answer, but at least consider TAVR for all. Consider, that's why I put it.